ಅಟೆಂಡ್ ಮಾಡೋದು ಅದೆಲ್ಲ ಫಸ್ಟ್
Asmila, shall I start now?
Yes, sir.
Okay. So, good evening to all of you. I will start with my first case now. All the three cases which are going to present are from Manipal Hospital. Courtesy to the PG students there. Now, I will, is my screen seen?
Yes, sir. Yes, sir.
Okay, right. The first case is a story of a 70-year-old man. He is an old case of coronary artery disease on pacemaker. It was an old model pacemaker. He developed herpes zoster in the right cheek and the side of the nose 3 weeks back. It was treated and the lesion subsided. He has now come with history and difficulty in swallowing 3 days back. Next day, he noticed imbalance while walking with tendency to fall to right side. It's a short history. He had a herpes zoster on the face. That is 3 weeks back. Now he's come with difficulty in swallowing and imbalance while walking with tendency to fall to the right side. This is herpes zoster on the side of the nose. You can see the pigmentation there. We subsided now. Now on examination, here a few jerk nystagmus on looking to the left side, fast component to the left. Nothing obvious could make out on looking to the right side. Okay, there is some mild rotary component on the right eye, but left side horizontal nystagmus is there. Ocular movements are all normal. Here, finally had a ptosis on the left side, but that is not a real ptosis. It's correctable on looking up. Probably a element facial palsy on the right side. That may be the reason why he is left ptosis on the left side. Element facial palsy on the right side. His palate is moving towards the left side, right antenna palsy.
Okay. Then say okay. Okay.
Tongue movements were normal.
Open once again.
Touching the pain, he seen decreased pain on the right upper part of the face.
Andre, right side there is an impairment.
The right side.
But over the face, cheek and the mandible area is normal.
ಒಳ್ಳೆಯದು.
Okay.
ಸೇಮ್ ಸರ್. ಈಗ ಏನೋ ವ್ಯತ್ಯಾಸ ಇದೆಯಾ?
ಇಲ್ಲಿ ಸ್ವಲ್ಪ ವ್ಯತ್ಯಾಸ ಬರುತ್ತೆ.
ಅಲ್ಲಿ ರೈಟ್ ಸೈಡ್ there is a
decrease on the right side of the. However, the corneal reflex was normal bilaterally.
Open देखो. Clench करें.
The motor fit was normal.
Bend करो. Open. Okay. Close. Open. Now it's not there. Close.
There was no saccadic lateral pulsion of the eye.
Slow.
Hearing was normal on both sides.
Okay. Don't see.
Come to the motor system, motor power normal.
Okay.
There is no finger nose incoordination.
ಹೃದಯ ಮುಟ್ಬೇಕು.
Okay. Take.
Lower limb power was normal.
Okay.
No lower limb incoordination was detected in the lower limbs. Gilson test was negative.
Okay.
Deep reflex were all normal bilaterally. Knee jacks were well elsitable. Ankle jacks were also normal. Plantar flexor.
ಏನೋ ವ್ಯತ್ಯಾಸ ಇದೆಯಾ ನಮ್ದು?
There is no pain difference between the right and left are equal.
ಒಂದೇ ತರ
Vibrations also equal bilaterally.
ಕೆಳಗಡೆ
ಗೊತ್ತಾಯ್ತು.
On standing, tends to fall VS to the right side. Especially when closing the eye, he falls to the right side. Tends to VS to the right side. When walking, he falls to the right side. So on examination, pupils normal, no Horner syndrome. Exocular movement is normal. Jack nystagmus on looking to the left side with the fast component to the left. Fifth cranial nerve decreased pain over the V1 area on the right side. However, corneal reflex was normal. Right element 7th nerve palsy. 8th nerve normal. Right 10th nerve palsy. 11th and 12th nerve normal. Motor system normal. DTR normal. Sensations over the body normal. Cerebellar sense no finger, nose, or heel shape coordination. But in standing patient, VS to the right side. So where is the localization and what is likely etiology in this patient? He has got right element 7th, 10th, and decreased pain on the right side of the forehead, and tendency to fall towards right side. And nystagmus is probably fast component only, but not present in the primary position, looking to the left side. Any thoughts?
Brainstem stroke.
Yeah, most like a stroke only. So which part of the brainstem is affected?
Right. Medulla.
But how to explain the right element alternate palsy on the right side? Medulla can explain everything except for the right element 7th nerve.
Sir, because apparent seventh nerve, sir, that it descends downwards till the medulla, sir.
Yeah, correct.
Explain.
Right, I'll tell you that fibers, some of the facial fibers descend down to the medulla and cross to the opposite side ascend, but that is only for the lower part of the face. So medullary lesion can produce paralysis of the lower face, but not the upper face. Upper face means he has got to have an element paralysis. That cannot occur with a medullary lesion. For putting it other words, medullary lesion will not produce a facial paralysis affecting the upper face.
It's a Ramsay-Hunt syndrome with 7th vestibular, 8th, 9th, 10th cranial nerve palsy.
Pardon?
It's a Ramsay-Hunt syndrome affecting the 7th nerve, 9th, 10th, and vestibular part of 8th cranial nerve.
Okay, that's perfectly fine. But he never complained any vertigo or anything. Anyway, that's a good possibility. But then he, on walking, it tends to fall towards right side.
Sir, was there any skew, sir?
No skew deviation.
Sir, is there any findings to indicate an intraaxial lesion, sir?
No, only thing is that there was no convincing evidence other than that it tends to fall to the right side while walking.
So then it can be intraaxial, sir.
It has to be intraaxial. Brainstem.
It's
Okay.
difficult to explain intraaxial.
Why difficult here? He has got tendency to fall towards right side, indicate right cerebellar involvement or his connection involvement or lateral pulsion of the body.
Sir, others are all element cranial nerve
Correct.
involvement, sir.
Perfectly right. Others are all element cranial nerve.
So the herpetic lesion of the 7th nerve, right 7th.
Pardon?
Herpetic lesion of the right 7th.
Yeah, of course. That's the best possibility. Can have the articulation with the 7th adjoining. The other doctor was telling, no, that's perfectly you can think of there's a logical thinking to explain. Multiple cranial nerve means you have to think of polyherpes. That is a herpetic affection of the adjoining cranial is well known. You can have 7th, 8th, 5th, all can get involved. But there's the patient has got tendency to fall right side without any vertigo or anything. That's the problem.
Sir, what about the head impulse test, sir? Head impulse is positive.
Okay, right. Let us see. So right pontomedullary infarct has to be ruled out because sometimes, the pica territory can supply the territory of anterior cerebellar artery. Anterior cerebellar artery can supply the medullary also because just like any artery territory in the brain, if one is dominant, the other artery may be subdued. So it can encroach on the territory of the vascular supply. It's well known. So that's one possibility. So what investigation you want to rule out infarct? MRI, no?
MRI brain.
But MRI could not be done since he was on a non-compatible pacemaker. And CT scan was done along with CT angio. Also the CT scan. Suspicious hypointensity in the anterior medulla are not very definite. That is the area we showed a suspicious hypointensity, not very convincing. That area. So what do you want me to do now?
Blink reflex, sir.
This is angio. Pardon?
Blink reflex, sir.
What reflex?
Blink reflex, sir.
You mean what is the idea of doing blink reflex? It's good to find out the afferent different body. So afferent is already affected. Afferent is also likely is involved because of the decreased pain on the right side. But is it going to give an advantage?
Sir, we can differentiate peripheral from central from the blink reflex, no, sir.
If it is already peripherally affected, that will be difficult.
So there is a definite cerebellar involvement because he is swaying to the right.
Yeah, saying right side, correct.
So there is a stroke.
Okay, so which is probably not seen, agreed. Okay, now I wanted to rule one test that whether it is entirely peripheral nerve, what peripheral nerve lesion can produce swaying to right side. If so, then we can do that test. Otherwise, you have to take it as an infarct. What test, bedside test will you do?
Static lateral position.
Very good. Head impulse test. Because the infarct could be multiple cranial palsy for a herpes zoster. So the only point against multiple neuropathy is lateral pulsion. The other situation where it can produce acute lateral pulsion is that acute vestibulopathy. Usually agree with you that produce vertigo. But he did not come any vertigo. Okay. Now the question is why to sort out whether it's acute vestibulopathy or not, what test he can do. These are the odd points against this thing, but nystagmus is there that can favor a peripheral nystagmus. This is a head impulse test. That is left side is normal. Right side, see, he has got a head thrust positive. Head impulse test is positive on turning to the right side. I'll show once again. Did you see that? That's it. That's all. So what is the final diagnosis now?
The Ramsey-Hunt syndrome.
Right-sided vestibulopathy, sir.
Correct. Vestibulopathy. It was surprising they never complained about vertigo, but it's also surprising because it's not fitting with the vascular territory, all points of peripheral, but his lateral pulsion is so convenient, no undoubted lateral pulsion. That is his complaint also, tendency to fall to one side. But no other signs pointing to the brainstem. Somebody also initially asked me whether it was done or not. It's actually done. I did not tell you in the beginning. Okay, the idea of bring the case is that sometimes when we can't do the necessary investigation like MRI, you have to heavily depend upon your clinical skill to differentiate whether it's peripheral or not. So this patient was put on acyclovir and steroid with this improved. Okay, any questions?
Sir, even in superior cerebral artery stroke, patient can have positive head impulse test.
No,
So
in fact,
it is not
what you said is perfectly right. If this vestibular root entry zone is affected, you can have positive impulse test. That's not against. But it is not only confined to the root entry zone here. The medulla is also affected, no?
okay, sir.
Regarding when there is a nystagmus and limb incoordination, if it is opposite, for example, if it is a left beating nystagmus with the right sided incoordination, then it favors vestibulopathy. And if
Yeah.
there is a right beating nystagmus with the right sided same side incoordination is there, it favors cerebellum.
Okay. Now I'll tell you, I'll answer to that. See, what he said is correct. Here, the nystagmus is beaten to the left side. That is favoring a right vestibular nerve involvement, vestibulopathy. Perfectly right. But remember that a medullary lesion on the right side can also produce a nystagmus beaten to the left side, mimicking a peripheral vestibular nerve involvement. That is called the pseudo vestibular neuritis. I think I've shown some cases before also. So as you said correctly, the nystagmus is typical of peripheral vestibulopathy, but that can also occur in medullary lesion. That is point number one. Second, here the difficulty was the other point against a medullary lesion is that such a medullary involvement producing tendinous and nystagmus, his saccadic lateral pulsion was negative. That is why I showed initially when I examined the cranial nerve, there was no saccadic lateral. That's the only point by which you can differentiate whether it's central peripheral here in this situation with MRA where cannot be done. Looking for lateral pulsion, if saccadic lateral pulsion is present, it is favoring a brainstem, medullary involvement. If head thrust is present, it can occur in both central and peripheral, but more favoring a peripheral. So head thrust positivity in the absence of lateral pulsion, saccadic lateral pulsion favors a peripheral lesion. Moreover, all other things are favoring seventh nerve. Peripheral lesion. Say herpes zoster, the commonest nerve affected is seventh nerve. Then adjoining eighth is likely to be affected. Then adjoining ninth nerve is affected. So there's a sequence involvement in Ramsay syndrome. Okay. Any questions before go to the next one? Is it clear? Any doubts? Are you sure about what I have said? Have you understood what I said? Medullary lesion can produce pseudovestibular nystagmus mimicking that of a peripheral vestibulopathy.
So does this patient had any vesicle over the pharynx or the ear canal, sir?
No, that we don't know because this has happened 3 weeks back. He has now come with only 4 days back only I come with this nerve palsy. But basically the only what is left behind is the pigmentation. On the palate and all there was no vesicle seen. I mean the heel scar is not seen. Okay, shall I go to the next case?
Yes, sir.
It's a long case. Okay. Not that long, still is a good case. It's a story of a 30-year-old man. He used to have low backache 3 months back, which used to radiate down the right lower limb up to the ankle. This was followed 1 week later by the similar radiating pain along the back of the left lower limb in a similar fashion. The pain was more at night. Is it radiating or not? We don't know. He's complaining of pain below, present also in the lower limb from the lower back. More at night, which used to wake him from his bed. However, there is no increase of the pain with coughing and sneezing. This was followed 1 month later by difficulty in getting him from sitting position, buckling of the right knee. That is the first thing I noticed, not the loosening of the chappals. At that time, there was no history of loosening the chappals, difficulty in putting on the chappals when he had buckling of the knee. And he also, along with they also noticed some wasting of the thigh also. The weakness gradually progressed and found difficulty in walking and needed support by one person to walk about after 1 month. Along with the weakness, he also noticed numbness on the dorsum of both feet, which later involved the anterior thigh region as well. For the last 2 months, he also noticed hesitancy and urgency in micturition. The past history, he was blind. The past, there is one past history, which may not be relevant to this case. He's got a thysis pulvi on the right hip. I just noticed on birth onwards. Most likely it's unrelated one. So this is the story once again I will tell. Low back ache and pain in both the lower limb, which is more at night, not increased by coughing and sneezing. However, easily was radiating below the back. Then 1 month later noticed difficulty in getting up squatting position and buckling of the right knee with wasting of that muscle. And that time there is no history of loose. That is very clear. I asked, it was not there at that point of time, loosening of the chapels. The weakness gradually progressed and found difficulty in walking and needed support of one person to walk about 1 month later. Along with that, noticed numbness of the dorsum of both feet, which later involved the upper proximal part of the lower. Then developed bladder problems. So this is the video of the patient. Yes, good. Right eye is smaller because it is sunken and smaller compared to the left eye is normal. And there is failure of abduction of the right eye.
It's got a microphalmia. You can
Being conjunctival worry has got a conjunctival atelectus replace a widow not.
നെല്ലോട്ട് നോക്കിക്കേ നോക്ക് ഇടത്തോട്ട് നോക്ക് വലത്തോട്ട് അറ്റം നോക്കിക്കേ താഴെ നോക്കിക്കേ മുകളിൽ നോക്കിക്കേ താഴെ വലത്തോട്ട് അറ്റം നോക്ക്.
Incomplete abduction. The rest of the cranials are all normal.
ഇടത്തോട്ട് ഇവിടെ
The motor sense examination, there was no obvious wasting in the upper limb. The tone power was normal.
ഇങ്ങനെ പോയി ലെവൽ ഇങ്ങനെ മടി
Deltoid power normal. Biceps normal.
നോക്കത്തെ വെട്ടിപ്പൊടി
Supinated triceps normal.
ഇതും പൊക്ക്
Finger extensions, wrist extensions, and finger extensions were normal power. Abductors, adductors of the fingers, long finger pulses are all normal. There was no finger nose incoordination in the upper lip. Trying to do the beaver sign, he was unable to flex the neck properly. I could easily bring it down. Probably indicating this either neck muscle weakness or abdominal muscle weakness. Lower limb, there was wasting of thigh. Both thigh and proximal and distal part also wasted. More wasting was the thigh muscle. And if flexion was made weak bilaterally, more weak on the right side. Knee extension was also weak. More weak on the right side compared to the left side. Knee adduction was normal. Hip adduction was normal. Abduction was weak bilaterally. More weakness noticed on the right side. Hip extension is also weak. That is more powerful than on the right side. Knee flexion is also weak, more weak on the right. Hamstrings are weak bilaterally. That's weak more. Easily I can overcome on the right side. Dorsiflexion was weak on the right side. But left was good power, about 4 to 4 plus power was good dorsiflexion. Plantar flexion was weak on the right side. But left was very good plantar flexion. The reflexes, biceps, normal bilaterally. Supinated decreased on the left side. Right side is there. Triceps was not elicited on the left side, but well elicited on the right side. Whether it is significant or not, we do not know, but I could not get it on that side.
Just പതുക്കെ
Finger pressure absent. Abdomen reflex that except the right lower quadrant, all both upper and lower part was absent. Both knee and ankle jacks were absent.
കൈ മുറുക്കി പിടിച്ച്
Even with reinforcement.
കൈ മുറുക്കി പിടിച്ച് മുറുക്കി പിടിച്ച്
Plantar was mute or indefinite. No response. That is only withdrawal. Test sensation was normal throughout.
ഇതൊക്കെ അറിയാം ഇതോ
Upper limb pain was normal.
എല്ലാം ഒരേപോലെ അറിയാം
But the lower limb,
ഉണ്ടോ എന്ന്
abdomen was, he is pointing to some level there.
ഒരേപോലെ ആണോ
At that, somewhere there his pain is more. There his pain is more. There, somewhere it is, the lower limb also
ഇവിടെ അറിയുന്നത് പോലെ അറിയുന്ന ഒരു വ്യത്യാസമാണ്
decrease in the feet. There, in the mid shin it is more.
നോർമലാണ്
That is maximal loss distally. Then the mid shin it is becomes little more, is able to appreciate.
ഇതും തമ്മിൽ അല്ല ഇതുപോലെ
But thigh and arm you compare, thigh also decreased.
ഇവിടെയും കുറവാണ് ഇതുപോലെ ഇല്ല ഇത് നല്ലതാണ് ഇത്
The pain is decreased below D6, maximum below the mid shin.
ഇവിടെ അറിയാം ഇവിടെയും കുറവുണ്ട് ഇതോ നന്നായിട്ട് അറിയാം
The upper part of chest is normal. Somewhere around the abdomen is the sensory level is pointing out.
ഇപ്പൊ തണുപ്പ് തോന്നുന്നില്ലേ ഇതുമാതിരി ഇവിടെയുണ്ട് അവിടെ കുറവാണ്
Temperature is decreased in the distal part of the lower limb.
കുറവാണ് ഇവിടെ ഉണ്ട് ഇവിടെയൊക്കെ ഉണ്ട് ഇവിടെ കുറവാണ് ഷിക്കറെന്നറിയാമല്ലോ
Vibration is normal in the upper limb.
ഉണ്ടെങ്കിൽ മാത്രമേ പറയാം ഉണ്ടല്ലോ ഇപ്പോഴോ ഇപ്പോഴോ ഉണ്ടാവും ഉണ്ടെങ്കിൽ മാത്രമേ പറയാം
It's absent in the feet.
ഇനി ഈ വൈബ്രേഷൻ ഇന്നോളം പറയണം നിൽക്കുമ്പോൾ പറയണം ഇപ്പോൾ ഉണ്ടോ ഉണ്ട്
He is able to feel after subsidence of vibration in the feet. JP is impaired on both feet.
ഇപ്പോഴോ 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 പറയണേ ഇപ്പോഴോ 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 ഇപ്പോഴോ
Then gate, this is the gate.
തിരിച്ചു വന്ന് അവിടെ നിൽക്കും
Trombox is mildly positive.
Okay, still able to
He could stand on toes, but he could not stand on the toes he couldn't stand on toes and heel on the left side, not on the right side. I will show that thing once again.
അവിടെ നിൽക്കും
So he is able to stand on toes bilaterally more easily on the left side, but dorsiflexion right side is he could not stand on heel.
നോക്കിക്കേ ഞാൻ പിടിച്ചിട്ടുണ്ട്
You see the tunnel back is positive bilaterally, hip abduction is bilaterally significantly weak. He was not going up at all on the left side. Both sides it is sagging. Okay. So canus is got thysis bulb on the right side. There is abduction failure on that side. Rest of the canal is normal. Motor system, upper limbs, no wasting of any muscles, tone power normal in the upper limbs. On Beaver's testing, it was negative. However, he was unable to flex his trunk against resistance. Lower limbs wasting of both thigh and legs more on the right side. Tone normal. Power weakness of both hip flexes, right more weak compared to the left side. Hip abductors knee extensions, knee flexes, all weak bilaterally. Again, more weakness on the right side. Hip adduction was normal. Dorsal plantar flexion was grade 4 to 4 plus on the left side. Weak, so not 4 plus, almost 5 on the left side. Grade 4 on the right side. Why I have 5? Because he's able to stand on toes and heel. Plantar flexion weakness on the right side, normal on the left side. DTR normal biceps supinated triceps on the right side. Normal biceps on the left side, decreased supinated triceps on the left side. Lower limb, both knee jacks, ankle jacks are absent. Abdominal plus absent except the right lower quadrant. Plantar mute. Touch normal in both upper and lower limb. Pain decreased up to D7 level, but more impaired over the feet up to the shin. Impaired temperature of both feet and lower legs. Vibration is decreased over both feet, even though he was able to feel it. Comparing the upper side, upper part, it is less. Impaired JPS over both toes. He could stand on toes and heel on the left side, but not possible on the right leg. Right hip also is able to stand on toes for a short period of time, not on heel. So, this is any questions regarding the findings? Second clarification regarding the findings.
Hip extension, sir. Was it? What is the power, sir?
Hip is just weak bilaterally. That is sure.
Perianal sensation, sir.
Pardon?
Perianal sensations.
Perianal sensation I did not look for.
Vibration of the spine, sir, in level was seen, the vibration.
That also we did not look. Only feel. He was able to feel all the knee also is able to feel, except he is able to feel even the toes, but compared to the upper limb, it is less.
Sir, any fever or immunodeficiency?
Pardon?
Fever or immunodeficiency?
No history of fever or anything. The duration is about 2 to 3 months.
It could be a
Spine
myelor
tenderness, sir.
radiculopathy, sir.
Okay, very good. Myeloradiculopathy. Any other possibility? If someone else
Spine
is
tenderness, sir.
no spine tenderness, nothing. He combined a low backache radiating pain down the lower limb, but there's no spine tenderness.
Epidural abscess is a possibility.
No, first of all, no, you have to localize. Then only never tell a diagnosis initially. Where is the site? Then we can think about if it is
Sensory motor syndrome. Sensory motor syndrome with possible element bladder favoring cardiac venous lesion, sir.
Cardiac vena. That's radiculopathy. Somebody is telling. Okay, cardiac vena. But what is against a cardiac vena? He has got a sensory level up to somewhere around D7, and his abdominal muscles are weak because on testing the beavers, I could easily bring the head backward. The neck flexion was weak. The sense that neck flexion movement was weak. That indicate that abdominal muscles, anti-abdominal muscles are weak. Now, you suppose you examine the neck flexion in the lying position. You are testing not only neck flexion, but also the abdominal muscle, anti-abdominal muscles. Because on lying down, the anti-abdominal muscles to contract to prevent the thoracic cage going upward when you flex the neck. And that is the principle of doing the beaver sign. The beaver sign, we ask the patient flex the neck only, but you're looking for the abdominal muscle contraction. So here his neck flexion appeared weak probably because the abdominal muscles are also weak. That is, abdominal is also absent except for the right lower quadrant. But not significantly, severely weak, but I could feel palpate the muscle, little bit muscle contraction in the abdominal wall. Abdominal muscles. Okay, any other thoughts by anyone? It's a tricky case. Okay, let's see. So first thing come to mind is who's got a myelopathy. Sorry, not radical neuropathy, has got a myelopathy with a radiculopathy, myelor radiculopathy, or radical neuropathy, because he has no definite evidence of any myelopathy. All can be explained by LM, and only thing is extending up to the trunk. So it may be intramedullary lesion of the cord, the lower thoracic lumbar cord. That also can explain, no? Primarily LMN. Because it's involved the anterior horn cells spreading from the lower thoracic down again, produce the same thing. Agree with me? Okay. What is against radiculopathy or cardiac annihilation? Already 1 point you have said. But still you can explain the suppose you have got a meningitis or pachymeningitis, leptomeningitis. Can affect the chorda equina. If the meningitis explains proximally, it can also affect the thoracic nerves, thoracic roots also. There also you can get the same thing. Agreed. Are you following me?
Yes, sir.
Yeah. But there are definite points against a radiculopathy in this patient. Can you tell me that in this patient from the examination?
Hip abduction versus hip flexions.
And that hip flexion can be weak by both roots can be affected.
Hip abduction is normal, but hip flexion is weak. That is against the root, no, sir.
Not hip flexion, knee flexion.
Yes, sir.
Okay. So he has got a good plantar flexion, good dorsiflexion in the presence of weak knee flexion, the presence of weak hip abduction. That is the point against. Because hip abduction, knee flexion, the same roots which supply the dorsiflexion, plantar flexion. They are on the, you can even stand on toes and feet, toes and heel on the left side. But then muscles are markedly weak. So that tells you that just cannot go with either a nerve involvement nor a root involvement.
Intramedullary, sir.
Yeah, correct. So we are thinking. So he has grade 5 power on the left dorsiflexus and plantar flexus on the left side with significant weak knee flexion hip up. That's against the radiculopathy. Now it's also odd because the sciatic nerve is supplying the hamstrings, but sciatic nerve supplies the plantar flexor. That is good power. And the dorsiflexion, that is good power. So that is against the nerve involvement. So weakness. The other point is that has got quadriceps is weak, so markedly weak on the right side, but hip adduction is normal. So these 2 points tell you it is unlikely to be a radiculopathy. So what investigation you need in this patient?
MRI, sir.
Okay, MRI. In fact, he was extensively imaged in previous centers. The patient came with the MRI. I'll show the MRI. This is a 2 whole spine MRI. I'll show individual picture later on. This is a T2 spine. Then each one I will show you. This is cervical T2, sag. Then the dorsal sag. Lumbar sag. Okay. Then this is the axial T2, cervical and upper dorsal, bringing downward. It's a dorsal spine, upper dorsal spine. Then lower dorsal lumbar T2 axial.
May look like some hypertension within the cord.
That is a lower dorsal spine cord.
Take only up to that level.
Unfortunately, it'll take only
Looks like some hypertension.
then I'll show the other one. Again, dorsal cord and thin axial.
See this one? It is a corner.
Then the chorda equina.
That is not around that we expect to be normal.
Then this is cervical TRE sequence. Then the dorsal. So there are so many pictures they are taken. Dorsal T1. Then T1 fat set sequence. Then dorsal spine stir sequence. So that is reported there is reported as MRI normal. So what else you want to do now?
So is it normal, sir? The cauda icona looks bulky, no, sir?
The cauda, you mean the lower corners, epicorners. Is it what you meant?
Yes, sir.
Cauda?
Cauda conus region, and this hyperintensive is a cord also, no, sir? Some dorsal region.
This one? Let me see. Show you once again.
The roots appear to be bulky, no, sir? The cauda region.
Cauda roots are not bulky. I'll show the roots again. I'll show that one again. This is the next one. Sorry, this one. Let us see the cauda icona roots.
See this one?
That is the epicornus region. Then coming down,
It is
there are the roots.
Cauda icona.
That does not appear bulky. Normal only.
Sagittal also, sir, it's normal, sir. The cauda conus region, sir.
Now let me see the sagittal. This is a sagittal cut. Normally also corners are slightly bulky. You can slightly increase, you can think, okay, so what do you want now?
Contrast, man.
Contrast was the film is it's not with them, it is said to be normal. That's the report I'll show that one. Before that, I'll show the other investigations also, before coming to that thing. What they have written, this is the NCA study. Upper limbs normal. Lower limb is also normal. Sorry, decreased amplitude in the right peroneal and the right femoral, both femoral. Left peroneal normal. Then tibialis and epicap was okay, but femoral was decreased. FAB latency is normal. Sensory potentials are also normal. This is snaps in the lower limb. So this is what they have written. See, this is from a very prestigious institute. They have a tendency to board. Sorry, forget about. I'll come to that later. Before that, the various investigations I will show, which was done earlier. Age reversal, alkaline phosphatase, LFT, serum folate, serum creatinine normal. Then LFT of normal. Then vitamin B12, ACA levels, creatine CPK, then phosphorus, then albumin globulin ratio, all things were calcium normal, thyroid functions are normal, diabetes workup normal. Then so this is their summary. This 53-year-old male person, weakness of bilateral lower limbs, paresthesia, bladder syndrome, history of recurrent episodes of vomiting, hypernatremia, possibly lumbosacral setbacks of the cauda syndrome was considered evaluated for the same. What is more important, the serum checks are normal, ANA profile normal, ANGA, ACA, RF negative, ASR is normal, serum D, vitamin D normal. PET was also done normal, MRI whole body was done normal. Official report awaited, patients planned for injection. This is the story. In fact, I asked about the CSF. They say CSF was done. That was reportedly normal. I had not seen the report. But they said the West African that is normal. They were told that it's just normal. In the colonoscopy, I'm sorry, colonoscopy, because it was abdominal pain, and that is also normal. Moderate colitis, active inflammation, biopsy, that's the thing. So what do you think now? What investigation you want?
CSF was done, sir.
CSF was done. That is the reportedly normal.
Contrast scan with detailed evaluation of the cauda conus lesion. Also EMG, sir.
Okay, EMG, how can it help? Because it's wasting is there, weakness, reflex. It's a low motor and paralysis. Okay, so the same thing I thought, but it's a site of lesion. Definitely it is in the conus epiconus region. Somewhere it is there because this pattern of muscle weakness cannot be explained by the root involvement nor the nerve involvement clinically. So it has to be in the anterior cells. Anterior cells were in the lower dorsals, that area should be affected. Then NCS also favoring a preganglionic lesion. So you want to repeat MRI dorsal spinal T2 axial. So this is the done there in KMC. Where I went there 2 days back. In the Manipal hospital, they did them. I asked them to repeat an MRI dorsal spine. But unfortunately, it is taken. This picture is taken from the screen, computer screen. That is the lower part epiconus region. That's the lower part. Okay. Then, so sagittal cut already we have shown before. Is it abnormal, normal?
So there is some hyperintensity now, sir, inside.
Exactly. So that is a suspicion. So, initially they said that it is normal. I asked the PE what they said it's normal. Then I wanted to see, but if you look very carefully, the lower part there is signal changes is there. See that one? The signal changes there. So I went down to the radial department, discussed with the neuroradiologist, and this is the picture. This is a sagittal. You can see some, the black, it should be black. It is some hyperintensities, even though not very typical. Now let us see the axial cut. This is upper part of spinal cord.
Intensity is still maintained. Okay.
Now go down, you can find the
there is no syringe or anything. As we come down, so this is the hyperintensity.
See, that is the abnormality.
Internal architecture.
That also a little more hyperintensity in the center also.
Yeah, they're all
see, that's almost filling in the cord.
Correct.
And this is where of course this conus bulb expansion.
See that one? It's no blackness is not there. Uniformly white.
Correct. Exactly. That also can. There also it is there. Yeah.
Then the conus side. So exact that is conus lesion definitely present.
Correct.
This is the normal signal intensity of the cord.
Right.
Go lower down, then the
hyperintensity.
That's hyperintensity in the cord.
Architecture totally changes to diffuse.
And the central gavite architecture is also changed. This is the thing on the sagittal and axial cut. So, what is the diagnosis now?
No.
Pardon? We can only say there is intramedullary lesion extending from the epiconus to conus region. So it may be more, it may be some mass lesion, we do not know. We have to go for a contrast study and the thin cut once again. And rule out a neural epipistle also. So I asked the possibility of AV fistula. Then he said there is only one abnormal that's not typical. So very unlikely to be dual AV fistula. Okay, that's the story of the patient. Now, why I brought the case? No, see, it was reported as normal before many times. But when the clinical suspicion is strong, when there is nothing else is possible, you have to persist and look for the lesion there. In fact, this after MRI was under the 3T test time machine. The patient could not afford anything, but I insisted. I went then and personally requested the radiologist to do it free. So the clinical examination is the one which guides you what to do next. So any questions?
Sir, I didn't hear the reason for that not being a dural AV fistula. Please, could you repeat that? Is it because it's more conus epiconus?
No, that's a favored site of a dural AV fistula. It's a favored site. The point is there was no abnormal vessel seen in the in the MRI. But remember, MRI need not always show abnormal vessels. They can be dural AV fistula, can be radiologically normal except for the hyperintensity in the cord. So when there is a strong suspicion, you should always investigate, do a spinal angio. Here the history was not fluctuating, not typical of a dual AV fistula, but that possibility still remains. But less likely because there is no abnormal vessel seen anywhere. Only one vessel could be seen. So you have to think of other possibility of a mass lesion or a MOG. That is the first possibility to be kept in mind.
Thanks, sir.
Can you make out the hyperdensity there within the cord? See, it should be black.
Yes, sir.
If you go back to the first film also, if you see that first one with the broad, the CD with a broad. See that film also, you can see hyperdensity there. In the corner, see the hyperdensity there.
May look like some hyperdensity.
See that? That's hyperdensity.
It is stopped there.
Since it is uniformly present, it's got confused with the normal cord. Okay. Any questions? We go to the next one.
Why the sensory level up to D7, sir?
Because the lesion was ascending up to that level. Because he's being a central lesion, that's where the crossing fibers are affected. That is, the pain is lost, even though the post-collar sensation was less affected. His vibration was only minimally affected in the feet, but pain was lost up to that level. Even temperature also decreased in the feet. That's also another point favoring intramural lesion of the cord. You understood why it's because the intramural lesion is cutting off the crossing fibers, the pain and temperature carrying fibers. When the post-collar fibers are the posteriorly, they tend to be spared in intramural lesion. They can get involved if the lesion goes backward, but more affected will be pain and temperature fibers. Okay.
The CSF study done, sir?
CSF was reportedly done from the previous institute. That report will be normal.
Sir, what is the further plan, sir, for this patient?
The plan is to do a contrast study, and then we have put the patient on empirically treatment for more till the contrast is available. We don't want to waste time. If it turns out to be something like a tumor, then you have to proceed accordingly. We have to repeat contrast with a thin cut. But already contrasted earlier, so less likely to be a tumor. Even PET was also done earlier.
So can be IgG related also, sir, sometime?
No, that's mainly basically dural based or leptomeningeal based lesion. Here is the intramedullary lesion. Okay.
Sir, but eye lesion was seen since very long time, no, sir?
Which one?
His eye, he had right thysis bulbi.
No, I don't know the explanation for that. That is a present from birth onwards. The small eye and the appealer protection. Shall we stop here, or one more case you want?
One more case, sir.
Yeah, because I want to wind up by 9:30 today. We had some other meeting to go. So this 56-year-old man noticed low backache associated with radiating pain from the back of both lower limbs, which is mainly on standing and walking. Along with this complaint, he also noticed radiating paresthesia along the back of both legs on standing and walking, lead by sitting, typical step of neurogenic claudication. Within 1 to 2 weeks, he noticed difficulty in walking with tendency to fall and needed support of a person to walk about. So this is the patient. Trainers are all normal. Upper limb tone power normal. Then check with the antibiotic is negative. Just like in the previous patient, I could also the flexion of the neck was weak. The lower limb is hypotonic. Hip flexion was weak bilaterally, not even lifted up against cavity. More weak on the right side. You cannot keep it against the gravity on the right side. It is so weak. Weakness was present on the left side also, but better than on the right side. Knee action is also weak bilaterally, more weak on the right side. Hip adduction was normal. Abduction was weak bilaterally. Hip extension was weak bilaterally. Knee flexion was weak bilaterally. Respiration was also weak. Plantar is also weak bilaterally. Come to the reflexes normal in the upper limb. Abdominal reflex was intact on both upper and lower quadrant. Both knee and ankle jacks were absent. Plantar was mute. Sensation, touch, normal in both upper and lower limb. This one. Alright. 10 minutes. Is there, no? Yeah, 10 minutes. 10 minutes. 10 minutes. 10 minutes. Pain was also normal. Vibration, you could feel the vibration on the feet. But joint sense was absent in the feet.
Now it's a pain. Now it's not sure. Okay. Now it's a pain.
SLR was negative. He could not stand on heel or feet. He has got hip abduction was also weak. This is how you walk with bilateral waddling. Or 10 bags per week. That was positive. So examination guidelines normal, upper limbs normal. PVS sign negative, but he could not flex the neck against force on lying down. Lower limb hypertonia, both the lower limbs. All muscles were weak in the lower limb except for the adductors. Weakness was more in the right lower limb. DTR normal in the upper limb. Lower limbs, both knee and ankle jacks were absent. Abdominal reflex present in non-fault quadrants. Plantar mute. Sense system all normal except for the impaired JPS on both toes. SLR negative bilaterally, paddling gait. Stands you could not stand on toes or heels. So what is the diagnosis? Localization diagnosis.
Cauda lesion, sir.
Okay. Any other thoughts?
It is almost like that of the previous case, sir. But,
Okay.
but there are certain subtle changes, sir, here. Like your the sensory component, whatever you have told regarding the sensory component, that is more affected in the previous case.
Correct.
Here, yeah, and there is no sensory level also in this case.
Okay, in the interest of time, I'll tell you this is not a cauda lesion because when hip flexion is weak, it is not cauda. Cauda roots are from L2 downward. If L1 roots are affected by some compression of the cauda, the corners also will get involved. Moreover, the abdomen is also weak in this patient. That is the point. Whenever you get hip flexion is weak, think away from a cauda compression. Okay, so what investigation you want? This is the MRI. MRI shows a disc at L1, L2 level. See the large disc in L1, L2 level. It's a disc there. That is a disc I will show you. Then this is the axial cut. Going up. You can see large disc at this level, L1, L2 level. Disc compressing the L1, L2. You can see the disc protrusion. So what do you want to do? Surgery?
Yes, sir.
In fact, he was admitted in the neurosurgery department. Then one of the neurosurgeons thought it cannot be, that is why he referred the case to me. So I said it is nothing to do with the tumor. Disc may be there, but its weakness is not due to that. Most likely it's something like a CAD. So what do you want me to do?
NCS.
NCS.
So
See the NCS?
Neck muscle is also weak.
Pardon?
Neck muscle is also weak.
Yeah, that's another point. Neck muscle, because that means abdominal muscles are also weak. That's the point again. So NCS was done. See the NCS? Normal amplitude. Velocity normal. Sensory potential normal. Yeah, I suspect it. We expect it in radicopathy pretty normal. Here it is normal. Say phase latency is again normal. 45, 50, 49, 48. So you now condition does not show any evidence of CADP. Then surgery.
EMG.
H reflexor.
H reflex should have been done. It is not done.
EMG.
But anyway, yeah, pardon. H reflex will also absolutely show the lesion is that is one thing we can do that, but only can check only one route.
What about EMG, sir?
EMG cannot help really in this patient. The DD is between CSF has to be done, correct. CSF has to be done, which can help. But even protein elevation can occur with the disprolapse, large disprolapse and can occur. But that is one test which you can do. Okay, so what do you want to know? I want to see the waveform. So it's just the waveform. There is no dispersion in the motor conduction. See, there is no dispersion. Conperonal nerve. No immediate dispersion. That's a demyelination here. There is no dispersion. Sensory potential is very acceptable. Saphenous, femoral cutaneous nerve. And this is the FA. Conperonal nerve on the right side. Conperonal on the left side. TBL on the right side, TBL on the left side. So, what is the diagnosis? Cardiac vena, go for surgery.
Upper limb done, sir.
Upper limb is normal, conduction was normal.
FA was impersistent, sir.
FA was impaired in one case, no, sir?
Yes, very well. I'll show you. Right. So,
Peritoneum. Only
recheck
3 are
this.
there, sir.
Right, very good, very good. You picked up that. See, this, I'll tell you, see, anyway, whatever you got a dot, go and check the base by US. That's what it exactly. So the report says, the surgeon says, sir, you said this is a CADP, the sensory conduction, NCS is normal, then why don't you go ahead with the surgery and all? Then, no, I want to see the FA. So this is the right FA, it's normal, this is the pattern should be there. See, no way should be equal also because the FA, the anticonstal pool stimulated is different at different times. So you will not get a uniform morphology, different morphology as here. Okay. So this is on the right tibial now, correct. Left tibial also correct. Now look at this now. See, this is the right. What is happening here? See, the morphology of the wave is exactly the same from top to bottom. That shows there's some problem in that's not a FA at all. And it is coming exactly at the same level. You got the point. Normally FA will come with some disparity will be there. One coming before, one coming a little later. See, this is the normal FA should appear. But here it is coming exactly the same level and the morphology also exactly. That means it is not a true FA. Now look at the other one. As you pointed out, there's only 3 out of the 10 importance are there. There's a very low FA persistence. So that is the abnormality which we should think is called a CAD. This should not occur with the cardiac lesion because that indicates a prolonged latency. So patient was put on IVMP. That is the treatment. Okay, the lesson is that, see, clinically itself, even though the surgeon he presented as a disprolapse compressing it, and L1, L2 disprolapse will not produce compression of the L1 root. Okay, it has to be a little above that. That should compress the corners region of the spinal cord. Second point is abdominal, Monsar was telling, abdominal muscles are also weak. Third point, if you look at the sensory, see, if the root is compressed, we expect the sensory in the distribution of the nerve root. Here, all sensations are normal, predominantly motor. Only abnormality, even vibration is also normal. Only abnormality was JPS over the big toe. It's predominantly motor involvement, less of sensory. That too, not in a dermatomal pattern. Thirdly, so look at the FA. That's the last one. So the clinical things you should give importance rather than anything else. Okay.
Sir, in cardiac vena lesions, the amplitude of the wave will be decreased, sir, in CMAP?
Yeah, it can decrease. Anywhere lesion below the anterior constal amplitude can be decreased. Even in the anterior constal or anterior root, amplitude will be, CMAP amplitude will be decreased. But
Okay, sir, thank you.
then SNAP will be retained.
Okay, sir.
The SNAP to go, it should be distal to the ganglion.
So one more theoretical possibility, if the sensory radical is compressed by the disc, and then
Yeah.
too we can have an FA prolongation link, sir.
Yeah, they can have a prolongation. But remember that here what is happening, not only one nerve, within the nerve, some of them are conducting normally, some of them are not conducting normally. There is a
His ataxia was more predominant lung, sir.
pardon?
He had
Pardon?
ataxia, much of ataxia, sensory ataxia, even though only his JPS was implanted.
No, inertial ataxia is a weakness, a significant weakness. That is why he's walking.
Okay, sir. He had some.
And that is because the significant posterior muscle weak, hip abductors are so much weak. That is, he cannot stand, no? He's swaying to either side. Because of severe weakness at the hip. In fact, all muscles were weak. Except the adduction, all of the muscles were weak.
Okay, okay, sir.
Okay. So shall I close here?
Okay, sir. Thank you, sir.
Okay, sir. Thank you, sir. Thank you,
Thank you.
sir.
We'll
Good
see you
night,
next.
sir. Good night, sir. Good night.
Thank you, sir.
Thank you.
Thank you, sir. Good night.
Thank you.